Good morning, everyone. At the outset, I would like to thank Dr. Ramandeep Singh for giving me this opportunity. So why this talk? Because as Sir has just mentioned, India is has the third largest highest number of HIV people in the world. And if 10 people in the Asia Pacific region are HIV positive, then 4 out of 10 of these will be in India. So as we now know what are the common anterior segment and posterior segment manifestations of HIV, so as ophthalmic surgeons, we may be called upon to operate these patients for various indications which may be HIV related like RD following CMV retinitis or non-HIV related like plain and simple cataract surgery in an emergency or an elective setting. It is important that we do not discriminate the HIV positive patients from the HIV negative ones, and the common universal precautions which Dr. Sunil has mentioned has and should be followed for all patients in general. But in known HIV positive patients, certain questions do crop up in our minds, like what is the risk of transmission, what should be the precautions during the procedure, and when to consider post-exposure prophylaxis and what drugs to use. This is because the standard steps of the surgery itself will not change and will be the same as we are doing for other HIV negative individuals. So as Dr. Sunil has mentioned, the risk of transmission for after percutaneous exposure to HIV infected blood is approximately 0.3% without treatment. And this is much less if we consider hepatitis B around 30% and hepatitis C, which is about 3%. The potentially infectious body fluids are also categorized into those which are at high risk and those which are not at risk. So at risk in fluids, if we come in contact with blood, semen, vaginal secretions, CSF, synovial, pleural, peritoneal or pericardial fluids and amniotic fluids or other body fluids if they contain visible blood. And tears, sweat, urine and feces and saliva are put down at a relatively lower risk unless of course these secretions contain visible blood. So as far as the risk of transmission is concerned, blood-borne or blood transfusion has the highest risk and needle stick exposures have a lower risk, 0.3%. Mucous membrane splashes to the eye or to the oronasal cavity have 0.09% risk. What needles? There is an increased risk if there is visible blood on the needle or the procedure involved placement of the needle into an artery or the vein. And more is the risk if the blood was drawn from a patient who has advanced AIDS, that is clinical stage 3 or 4 or any clinical stage if the CD4 counts are less than 350. The risk is higher if the needle is hollow and higher if the penetration is deep, that is if there was significant amount of pain associated with the needle stick exposure and it was associated with significant amount of ooze of blood. So what can cause needle stick exposures? Most common causes can be simple lack of concentration, simple inexperience, lack of concern, and improper disposal of sharps. It is very important that we do not break, bend, recap, or reuse the syringes or the needles when we are using them. The risk of infection is higher if the surgery is prolonged more than 3 hours or there is more than 300 ml of blood loss during the surgery, which is not common for routine ophthalmic surgeries. There are little reports on whether or not we should be screening all patients for who we are planning to take up for surgery for HIV. And there have been some studies, especially in Africa, where the prevalence of HIV itself is higher. And they have found that in rural camp settings, the prevalence for routine screening range from 0.3% to 3.7% in a hospital-based setting. So there is questionable value of whether we should be getting HIV tests done for all the patients. And by and large, it is not recommended unless in certain situations where the prevalence of HIV itself in the area is very high. Again, the risk is greatest at the time of seroconversion, when the viral loads are higher and those who are not on antiretroviral therapy. Also, the risk is higher if the viral load is higher. And it is very important that despite HIV coming out to be negative, there may be a proportion of patients who will be in the period of seroconversion, which is around 3 to 6 weeks. So you may be very happy that the HIV test has come out to be negative, But in fact, the patient may be harboring the virus, and it may be just a few weeks more when the test may turn out to be positive. So it is very important, as Dr. Sunil has just talked, to follow the universal precautions in all patients and treat all patients as if they were potentially infected. So, body isolation with waterproof gowns, face masks, safety goggles, and use of boots rather than open-toed shoes is recommended. And it is hand washing technique, which is very simple, should be followed in routine clinical practice. 2 pairs of gloves whenever direct contact with blood or fluids is expected should be used, and the larger size of the glove should be worn on the inside next to the skin and a half size smaller on the outer side. The procedure should be carried out in a slow and orderly manner. The surgical assistance at the time of surgery should be kept to a minimum. Reduce the number of staff in the OT to cover the essential roles only. Remove all extra and unneeded equipment from the OR room. Staff with abrasions, eczema, etc. should be excluded from the procedure, and as far as possible use disposable instruments and minimally invasive techniques. Like we see here that we have covered the foot paddles of the vitrectomy machines and the laser machine with a disposable plastic sheet. The shafts, it is very important that the shafts should be placed directly on the trolley instead of passing to and fro with hands, and do not take the instrument, a sharp instrument, from the hand of a nurse, but directly keep it on the trolley, or alternatively use a kidney tray to pass the instruments. The assistant should be still when the surgeon is doing any delicate procedure like suturing or sharp dissection. Care should be taken to ensure meticulous hemostasis. Do not use one's hand to hold the suture needle. The shaft should be disposed of in puncture-proof containers, and they should be color-coded as per the standard guidelines. All swabs should be counted. The disposable instruments should be sealed and double-bagged, and they should be labeled with a hazard label. Soiled linen should be placed into special bags and also marked with a hazard label. All spills on the floor should be cleaned with a 10% solution of common household bleach. And then, after all this, despite this, if there has been some exposure, then we have to consider post-exposure prophylaxis. What does it mean? It refers to the comprehensive management given to minimize the risk of infection following potential exposure to blood-borne pathogens. As we know, the natural history of HIV disease has a period of 3 to 6 weeks which is known as the window period, where the antibody levels are coming up or the seroconversion taking place. So this is the period we have to cover with the use of post-exposure prophylaxis. What is defined as an exposure? An exposure has 4 basic categories. Either it is percutaneous injury, like as if with a needle stick or cut with a sharp instrument, or there can be a mucous membrane, contact with the mucous membrane of the eye or the mouth, or there is contact with the non-intact skin which is chapped, abraded or afflicted with dermatitis, or there is contact with an intact skin but the duration of contact is prolonged. So what steps should be followed in case you have had an exposure? These following 6 steps have to be followed. The first and foremost is to manage the exposure site immediately. Then establish whether or not you are eligible for post-exposure prophylaxis, and then if yes, then PEP has to be prescribed after proper counseling, followed by lab evaluation, follow-up and support. So how do you manage the exposure site immediately? This step has to be done immediately following the exposure. Remove the gloves if applicable, and immediately wash the wound with thorough amount with soap and water with thorough rinsing, or irrigate the exposed eye with water or normal saline. If you are wearing contact lenses, do not remove them immediately because they may act as a barrier, protective barrier, to prevent the penetration of the virus, and only remove the contact lenses after irrigation. If there has been splash into the mouth, spit the fluid immediately and rinse the mouth with water or saline several times. It is very important that you do not panic in such a situation. Do not put the prick finger in your mouth. Do not squeeze the wound to bleed it, and do not use bleach, chlorine, alcohol, betadine, iodine, or other antiseptics on the wound. This is as per the NACO guidelines issued in India. Then, the second step is to establish eligibility for PEP. This should also start as soon as possible. The initiation of the prophylaxis should not be delayed while awaiting the results of testing of the source or the exposure. In ideal situations, the first dose of the prophylaxis should be taken within the first 2 hours of the exposure, and there is no benefit of taking it beyond 72 hours. So, and it is also important that even if you have taken the first dose and the source test comes out to be negative, you can stop the prophylaxis and the subsequent doses immediately. So we have to assess the type and the source of the exposure to determine whether or not prophylaxis is actually required. We have to assess the exposed individual. We have to assess the source of the exposure and then determine the risk of transmission. So first we have to assess the exposure. So as I have mentioned, exposure can be mild, moderate, and severe. Mild is if there is contact with an intact skin, there is no indication of the prophylaxis. Then if the contact is on the mucous membrane or a non-intact skin, then you have to assess the volume of the exposure. If it is small, then it is classified as mild. If it is a large volume, then it is classified as moderate. And if there is percutaneous injury, you have to assess the severity. As Dr. Smeel had mentioned, that the severity is more if the bore of the needle is larger, that is more than 18 gauge. If the needle used was hollow, if the puncture was deeper, then it is severe. If either of these criteria are not met, then it is less severe and classified as moderate exposure. Then assessment of the source. You get an HIV test done. It can come out either negative or positive. At negative, either the patient is not infected or he is not yet seroconverted. If it is HIV positive, again it is low risk or high risk. Low risk when the viral loads are lower and the patient is clinically asymptomatic, but the test is positive. And high risk if the test is positive and the patient is clinically symptomatic and the viral loads are higher. Also, there can be a situation when you cannot detect or the source, the status of the source cannot be known, especially those workers who deal with the hospital waste management, because the patient will not be available to them. In such a situation, his or her blood will not be available for testing. Then you classify it as unknown. Then assessment of the exposed individual is also important. So after proper counseling, we have to test for any pre-existing HIV infection in the exposed person as well. Then, if indicated, the exposed individual has to be counseled for prophylaxis. He has to be explained the risk and benefits of the prophylaxis, and consent needs to be taken. He needs to be provided with psychological support. It is very, very important to allay his anxiety and even offer special leave from work to get the test done. Then, prescription of the prophylaxis. Basically, there are two regimens. A basic regimen has 2 drugs. An expanded regimen has 3 drugs. The duration of the prophylaxis is for 28 days or 4 weeks. So then, if the exposure is mild and the source is HIV positive but low risk, then you consider 2 drugs prophylaxis. If the exposure was mild but the patient was high risk HIV positive, then you have to start 2 drug prophylaxis. If the exposure was moderate but the patient was low risk HIV positive, then also prophylaxis with 2 drugs is indicated. If you moderate exposure in a high risk patient, then you need the expanded or the 3 drug regimen. If the exposure was severe and the source was low risk, then also you need the expanded regimen, and high risk, obviously you need the 3 drug regimen. If the status of the source was unknown and either the exposure was mild, moderate, severe, usually no prophylaxis needed except if the exposure was severe, then you may consider 2 drugs of prophylaxis. So the first choice as per the National AIDS Control Organization guidelines are zidovudine 300 milligrams BD and lamivudine 150 milligrams BD. The second choice is stavudine 300 milligrams BD and lamivudine 150 milligrams BD. For the expanded regimen, apart from the basic regimen, you have to add one of the protease inhibitors, which can be either lopinavir, ritonavir, melphinavir, or indinavir. In the West, Though the duration of the regimen is the same, the first choice is for the basic regimen is tenofovir or along with M-triacetabine, and the alternative is zidovudine and lamivudine. For the expanded regimen, either of ritonavir, lopinavir, darunavir are used, and as an alternative, darunavir, atazanavir, and raltegravir are used. It is also very important to exclude pregnancy if the healthcare professional is a female. In case the professional is pregnant, then the basic regimen though remains the same. For the expanded regimen, nelfinavir is the drug of choice, and efavirenz and indinavir are contraindicated in pregnancy. It is very important to counsel for potential side effects because these drugs have their own side effects. They may have nausea, vomiting, diarrhea, headache, fatigue, anemia, and possible drug interactions. So complete blood counts and LFT should be done at baseline and at week 2 and 4 after therapy. What should be the follow-up? Week 6, an HIV antibody testing should be done for the exposed individual. At the 3-month follow-up, again HIV testing along with HBs antigen, anti-HCV and LFTs at 6 months. So 6 months follow-up is needed following post-exposure prophylaxis. Again, these tests have to be repeated. So to conclude, HIV is a global pandemic. The risk of transmission during surgery is variable and it depends on the type of the exposure and the status of the source. So it is very important that we follow personal protection using universal precautions in all situations, which is the ideal setting. Do not isolate persons just because they are HIV positive, because they also deserve your respect. Thank you. Patients.